Hello, my name is Khersey, and today I'm going to be presenting my answers for Case Connections Unit 4. So the first case connection that I chose was case connection number 1. So we have here a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic test would be the best to distinguish between a urea cycle disorder and a disorder in the beta oxidation? We have choices blood glucose, urinary acids, serum fatty acids, and plasma glutamine. So to answer that question, the best diagnostic tests that would be able to distinguish between the urea cycle disorder and a disorder in beta oxidation would be plasma glutamine. The rationale behind this answer is that the diagnostic test will demonstrate a clear distinction because glutamine levels will be normal in beta oxidation disorders but are going to be elevated in urea cycle disorders. Glutamine, as we know, is a non-essential amino acid that transports ammonia. So when a urea cycle disorder is present, ammonia as well as the plasma glutamine levels will rise, and that's much like the blood work that we see in this patient here. So here we're just showing that the initial blood ammonia level was elevated and then increased even more, and then we also see that the plasma glutamine, the urine orotic acid levels were also elevated, but the plasma sertraline levels were normal. And so in this patient where the orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one that is least likely to be impaired. So what I came up with was that when orotic acids levels are elevated, a urea cycle enzyme that's most likely to be deficient is the ornithine transcarbamylase. And this type of deficiency is consistent with high levels of ammonia and orotic acid in the urine. In addition, this deficiency can lead to an increased production or accumulation of the carbamyl phosphate, as this enzyme transcarbamylase is not using the pool of the carbamyl phosphate to synthesize sertraline. This carbamyl phosphate will then be directed into pyrimidine synthesis in the cytosol, and that's what really causes the levels of orotic acid to rise in the urine, much like we see in this patient. And so an enzyme that would be least likely to be deficient or impaired would be the arginine succinate synthase. A deficiency in this enzyme would cause low or non-existent levels of urine orotate and high levels of blood sertraline, which is the opposite of what we see in this patient. In addition, an impairment in this enzyme would suggest that the carbamyl phosphate was not accumulating, and that also kind of strengthens why this would not be impaired, because we know we have accumulation of the carbamyl phosphate. So next I've chosen case connection is a 4-day-old infant is being followed in the clinic. Her birth weight was 5.9 pounds and the pregnancy and birth were normal. Results from newborn screening demonstrated a phenylalanine, a level of 6.6. A presumptive diagnosis was the phenylketonuria, and additional samples were obtained to further analyze. The parents deny a family history of PKU. So as a consequence of this presentation, which amino acid may become essential? And so to answer this question, I've chosen tyrosine. As we've learned, patients that have PKU may lack or have a deficiency in the phenylalanine hydroxylase enzyme. And typically hydroxylation of phenylalanine by this enzyme with the cofactor BH4 will form tyrosine. So when this enzyme is deficient, tyrosine becomes a conditional essential amino acid and it must be supplied from an exogenous source. So then we move on to the second part. So the phenylalanine dietary restriction therapy was initiated at 14 days of age with good response of plasma phenylalanine levels that dropped to within the normal range. So what are the potential causes of the presentation of PKU? So potential causes of this could be a mutation in the gene that produces the phenylalanine hydroxylase enzyme, and that would cause the accumulation of the phenylalanine in the blood and plasma. There could also be a deficiency or lack of cofactor BH4, which will result in similar symptoms of you would see if the enzyme was impaired. Lastly, we have another patient B who's also being evaluated for suspected PKU. BH4 loading tests are performed on both patients and the results are presented below. So we can see we have patient A in blue and patient B in the orange color. And then how would you summarize the results of this test for patient A and for patient B? So the results for patient A and B show that phenylalanine is increasing over time for the patient that's on the dietary restriction, but the levels are reducing in the patient that's having the BH4 loading. So this would lead to the suggestion that patient B may be lacking the cofactor BH4 rather than having a deficiency in the phenylalanine hydroxylase enzyme. Patient A may have a deficiency in the phenylalanine hydroxylase enzyme because we know from the information above that the patient responded well to the diet but is not responding as well to the BH4 loading test. And here are my references. Thank you very much.